2-year fellowship in acute care surgery. For those of you who don't know, Audrey had quite a successful career in finance, trading securities and managing portfolios in Palo Alto before she had her surgical awakening in 2008 and decided to pursue a passion and a career in medicine. Dr. Spencer went on to receive her medical degree at GW and left quite an impression there. Bhavik Sarani and the trauma group there still literally rant and rave about Audrey as one of their favorite students of all time. In 2015, we were lucky enough to match Audrey, and she began her surgical training here at Christiana Care. The two of us will forever be linked, as that was my chief year. And as I graduated, I awarded Audrey the Road Longest Traveled. This distinctive and prestigious award included my very own Danskos that I had worn for 5 years during training. While it may have seemed like a silly gesture, it was just my way of showing the respect and pride I had for all that Audrey had done already, even just as an intern. Today, I'm even prouder as she graduates with over 1,200 cases and has added numerous other committees and research projects to an already impressive CV. So without further ado, I'll hand over the reins to Dr. Audrey Spencer so she can add on one more thing to her CV, and that is the privilege of delivering surgical grand rounds. Audrey?
Thanks, Jay. Let me get the screen shared here really quickly. Okay. All right, good morning, everyone. Thanks, Jay, for that lovely introduction. And I'd like to begin by thanking everyone else for logging in remotely for grand rounds today. I know these aren't ideal circumstances for presenting, but I'll do my best to impart a lively lecture, and your attendance and participation is greatly appreciated. I'll be showing the CME code again at the end of the presentation, so if you haven't quite gotten to jot it down or if you're joining late, we'll revisit that again. I'd like to begin this morning's talk by saying that the decision to pursue trauma surgery as a career really wasn't an easy one for me. Many of you know that I struggled basically right up until the last moment with my decision, and that the idea of having to choose a single specialty above all the others was really, really difficult because I enjoyed facets of every specialty. And for me, they're all very intricately entwined and they blend together. So in my mind, practicing one specific version of surgery without enjoying all of them was really sad. So that's what has made residency such an incredible and unique experience for me. And as graduation approaches, I feel like, you know, I was sustaining this loss somehow by picking one specialty over the others. But, you know, I don't have to. I've realized that now. And in my search for a topic for grand rounds, I came to the realization that I was choosing a career path, but that I wasn't actually choosing between specialties. And that for me, there's a continuum that exists between all the subspecialties, and they all lend their own strengths and attributes to my skill set. So for this reason, I decided to go into trauma surgery and acute care surgery as a profession, because it was the one place where I felt like I could utilize basically everything that you all have taught me over the last 5 years. And I picked today's topic because its origins were based in the trauma world, but we can apply the techniques to almost any branch of surgery. And with that, I'd like to roll into today's topic, which is the surgical open abdomen. I've entitled this discussion, Bridging the Gap from Damage Control in Trauma Surgery to Universal Application of the Open Abdomen, because the open abdomen saw its origins in the foundations of trauma laparotomy. It's gone through various iterations and frequently has been the subject of scorn or criticism amongst other subspecialties. And yes, there has been some historical overutilization within the trauma world, but it certainly isn't without its own set of complications. But on the flip side, it's not without its benefits. And I'd like to talk about how the open abdomen can be applied to those of us not practicing within the realm of the trauma world. So I have no financial or professional disclosures. For the objectives today, I've broken down the lecture into essentially 3 sections. I've spent half of my undergraduate years taking history classes, and I have a minor in history, so no lecture for me would be complete without the historical component. I want to discuss where the idea of damage control surgery came from, how we first put it into practice, and how the trend began to catch on and spread. And then I'll talk about the scientific principles behind damage control surgery and what some of the earliest studies on the topic showed. Then we'll jump into a few case studies. They're all patients and surgeries I participated in the care for while I was a resident here at Christiana, just to show how necessary the open abdomen has become to non-trauma surgeons and how it provides a safety net for us when things don't go exactly according to plan. And then we'll wrap up the talk by going through some of the literature that supports how and why we use the open abdomen today. So this guy, this is George Goodfellow. It was a photograph taken of this gentleman in 1881. He was a civilian physician living in the Western territories of the United States in the late 19th century. He's largely credited with being the first civilian trauma surgeon, although that's probably up for debate. But he made a name for himself, especially in the realm of abdominal gunshot wounds. And he's really the first surgeon in the documented literature to pursue laparotomy for the treatment of intra-abdominal hemorrhage. Laparotomy at the time was reserved really for resection of organs related to acute infection or tumors. Any individual that sustained a penetrating injury to the abdomen was generally treated with conservative measures and lots of pain medication until they died. So really any hope of saving someone who was shot in the trunk was really thought to be futile at that point. So it wasn't all that long ago, you know, we're only talking 130 years ago, that Dr. Goodfellow figured out that survival was a possibility if you operated on someone with penetrating trauma. He gained a lot of notoriety after he established a local practice in Tombstone, Arizona. He operated on a number of the individuals involved in the shootout at the OK Corral, including several members of the Earp family. But in prepping for this lecture, I was pretty disheartened to learn that the large majority of my co-residents have never heard of the shootout at the OK Corral. So for any of you out there that are looking for something to do with your social distancing time, I highly recommend watching the movie called Tombstone. But back to this guy, you know, the truly fascinating thing about this man were that he published a number of treatises on the treatment of penetrating trauma to the abdomen. The Southern California Practitioner was a medical periodical that was published in the late 19th and early 20th century. Goodfellow was asked repeatedly to submit columns regarding his experiences in operating on abdominal trauma for gunshot wounds. And in volume 4 of the May 1889 issue, he wrote this, that given a wound of the abdominal cavity, what is the immediate result? Usually inevitable death from hemorrhage and from 15 minutes to a few hours at the most. There is no possibility of causing cessation of the flow by any procedure save one. If we temporize, the hemorrhage goes on, the shock increases, and the delay is fatal. Abdominal section affords the only means of relief. So it was really a profound statement at the time. He recognized something critical in his studies of gunshot victims, that by stopping the hemorrhage and controlling enteric spillage, you could increase the chance of survival. These people weren't doomed to a painful death. You could do something about it. Stopping the bleed and preventing contamination. They're two very, very, very simple concepts, but they were a totally novel idea 100 years ago. So to Dr. Goodfellow, not operating meant certain death if you were a gunshot victim, but laparotomy and damage control surgery, which was a term we wouldn't hear for many, many more years, really gave the patients their only hope of survival. So while Dr. Goodfellow didn't specifically utilize open abdominal management in its true form, or what we think of today, he was one of the first physicians to publish on intra-abdominal drainage for contaminated abdomens. So his description of various medical cases involved leaving water-soaked gauze and drainage tubing within the abdomen before closing the midline in some fashion. So in a sense, it was his recognition that infected and contaminated wounds needed some form of drainage. Festering wounds and abscesses were treated with incision and drainage, so really why not apply that principle to the abdominal cavity as well? So that brings us to one of the primary foundational concepts, which is source control. At a very basic level, we know that when the body sustains some form of insult, the natural response from the body is to evoke stimulus aimed at containing the insult. You want to limit the damage and then repair everything to restore natural function. Innate immunity confers the body's response, which includes inflammation, coagulation, and tissue repair. But what happens when that insult is so great that your immune system can't regulate the process on its own? The goal is essentially to maintain control and then promote healing without adding unnecessary insult to the patient that's already in extremis. So these same principles are what guide our purpose as surgeons, no matter what entity we're dealing with. And Goodfellow, whether he intended to or not, was really devising a way for surgeons to reestablish control in a process previously thought to be unsalvageable. And it would take another 100 years before what we know as the modern day damage control surgery would really begin to realize its full potential. This is someone we should all recognize. We know that from case reports that surgeons had been employing the open abdomen as early as the 1940s. Sir William Heneage Ogilvie, it's a heck of a name. He was a British surgeon who had a rather illustrious military career. He served through the Balkan War as well as both world wars. And he really took a special interest in diseases of the colon and colonic injuries. And he published a number of papers on delayed primary closure for abdominal war wounds. And he also described multiple cases of open abdominal management for intra-abdominal sepsis. So again, the concept is really simple. You have an infectious or an insulting nidus within a contained cavity, and you need to open and drain it to get source control. Sir Ogilvie's military career would bear witness to the discovery of penicillin, and he was primarily operating under wartime conditions where immediate or definitive intervention wasn't always possible. So really, the wartime context surrounding his career necessitated the development of these delayed closure techniques. Because of the limited resources and danger of caring for patients in the forward operating theaters, many patients had to have a way to be temporized until definitive care could be provided, because it wasn't going to happen on the front lines. So create a temporary fix, give the patient some antibiotics, because now we have good antibiotics, and then live to fight another day. Another example of this was Donald Steinberg. He was a general surgeon from Toledo, Ohio, operating around the same time, and he published several documents also as a proponent for open management for acute generalized peritonitis in the late 1970s. And we see this trend continue and then really blossom in the early to mid 1980s when we see a sudden surge within the scientific community with a number of papers describing open abdomen as a last resort technique for managing intra-abdominal sepsis when antibiotics, fluid resuscitation, et cetera, aren't enough. But it wasn't until a landmark article initially presented at the annual meeting of the Southern Surgical Association in '82, and then it was later published in the Annals of Surgery in May of '83, did we see the first comparison really between the standard operative interventions and then the first published form of the open abdomen for control of hemorrhage. The paper was entitled Management of the Major Coagulopathy with Onset During Laparotomy. The paper was submitted by H. Harlan Stone. He's one of the surgeons who was responsible for helping establish the trauma program at Grady Memorial Hospital down in Atlanta, Georgia. And he did a large component of his training and spent really many years of his professional career there. At the time the article was first presented, he had moved on to work at what we now know as shock trauma at the University of Maryland in Baltimore. And Dr. Stone was known at the time as one of the experts in surgical infections. It was really a niche specialty of his. And given that he spent a significant amount of time battling intra-abdominal infection as a surgeon, which is also one of the known complications of closing an abdomen following laparotomy, it comes as no surprise that he would be one of the first major proponents in utilizing the open abdomen for damage control. Now, the study itself wasn't exactly great by our modern day scientific standards, but it was the first of its kind that we can really find in the literature. And it included 31 patients total, so small sample size, all of whom had been admitted to the Grady Memorial Trauma Surgical Service. And it was between July 1976 and June of 1982. We don't know how the patients were selected. Very little was said about the actual inclusion criteria. And for me, it's really hard to imagine that in 6 years there were only 31 trauma laparotomies. But be that as it may, the first 14 patients, that's your control group, were treated over the course of the first 3 years. And 17 patients in the experimental arm were treated in the latter 3 years. The control group underwent what Stone refers to as standard laparotomy, in which the goal was to arrest bleeding and complete all components of the operation in totality, including resection, anastomosis, reconstruction, and permanent closure of the abdominal wall. The experimental arm underwent abbreviated laparotomies when a quote-unquote coagulopathy was noted with temporary abdominal packing under tension. So it means they had some sort of closure to create a tamponade effect, and when they were noted to have adequate clotting, they were brought back to the operating room for completion of their surgery. Patients included in the study ranged anywhere from age 17 to 67. The average age was 28. It included 25 men and 6 women. 22 of the patients were Black and 9 were white. If you look at the indications for operation, penetrating trauma was far and away the most common cause. 11 and 13 patients respectively, followed by blunt trauma. And then you'll see this also included a number of patients requiring surgery for non-traumatic causes, such as obstruction, mesenteric ischemia, pancreatitis, and diverticulitis. Now, we have to clarify that coagulopathy in this study was a completely subjective and observational variable. 25 of the patients had the absence of an observable clot. 5 patients had ongoing oozing from the surgical bed without an identifiable vessel to ligate. And the last patient was the only one to have clotting factor abnormalities as reported by the anesthesiologist intraoperatively. So there was no consistent measure of whatever they were calling a coagulopathy. When we terminate a surgery for coagulopathy secondary to a lethal triad, we are specifically looking for hypothermia, acidosis, and abnormal bleeding, usually defined by lab values such as thrombolastography or coagulation factors. Clotting factors were recorded for the patients included in the study, but they weren't directly used to determine the need for damage control operation. They were used instead for resuscitation guidelines. And in fact, a direct quote from the article is, specific measurements of various components of the clotting mechanism were used as only a guide to repletion, not as an indication of operability. So here's a brief look at some of the lab values recorded for the patients. You can see that clotting time was significantly prolonged in every patient, and that all patients had a relative thrombocytopenia, and only 2 patients had critically low fibrinogen levels. The primary outcome examined by Stone was mortality rate. 93% of the patients in the control arm died primarily from ongoing hemorrhage, although 1 was noted to die due to ongoing refractory shock, which you would think implies essentially the same thing. But by comparison, 11 of the patients in the experimental arm survived, equating to a 35% mortality rate with temporary abdominal packing. Secondary endpoints examined were blood product infused and other various complications of the procedures themselves. All patients, regardless of which arm they were in, experienced some form of complication. So that means wound infections, intra-abdominal abscess, fistula, pulmonary compromise, renal failure, etc. And if you look at the numbers, the traditional laparotomy patients required significantly more blood product, up to 35 liters of blood, which is a ton. So Stone concluded his article by stating that all bowel anastomoses should be diverted proximally to avoid fistula formation, and that delayed primary closure of the abdominal wounds themselves were recommended. The main takeaway, however, was that in a patient suffering from severe coagulopathy, temporary abdominal packing can assist in the arrest of the hemorrhage while guided resuscitation takes place. And the patient can return to the operating room at a later point for completion operation, and in so doing will likely improve their survival chances. So during the same time period, open abdominal management was actually more prevalent in the general surgery literature as it pertained to intra-abdominal sepsis. Surgical intervention for traumatic injury had been around for decades, but trauma is a subspecialty of surgery, and trauma systems themselves were still in their infancy at that point. So trauma surgeons as a group had not yet embraced the idea of the open abdomen despite Stone's published work. And yet that was really all going to change. And, you know, in comes the damage control surgery. So in 1993, Michael Rotondo, he trained at Jefferson, and he was now in the midst of a trauma critical care fellowship at Penn. He, along with several of his mentors, coined the term damage control surgery, and they published this study in the Journal of Trauma the same year. They looked at 46 patients requiring laparotomy for penetrating trauma. 22 were in the control group, which was traditional single-stage surgery where all components of the surgery were performed in one setting. The other 24 patients were in the experimental arm, which involved damage control laparotomy with take-back for completion of the necessary procedures once the patient had been resuscitated. Survival rates between the two groups in the study were actually very similar when initially looking at the numbers. However, when they broke the patients out into subgroups, they noted that the really severely injured patients, defined by the fact that they had at least a major vascular injury and 2 or more visceral injuries, those patients actually had improved survival, 77% versus 11%, if they underwent a damage control procedure. So damage control was a term that was first implemented by the United States Navy, and they used it to describe a ship's capacity to absorb damage and maintain mission integrity. Rotondo defined damage control as the initial control of hemorrhage and contamination, followed by intraperitoneal packing and rapid closure, which allows for resuscitation to normal physiology in the ICU and subsequent definitive re-exploration. Anecdotally, for a number of years, trauma surgeons had been observing an increase in patients presenting with these really high velocity, multiple projectile penetrating wounds, so bigger guns that were firing at a more rapid rate. And the traditional laparotomy for definitive control and repair of those injuries was no longer applicable to the rapidly expanding cohort of patients that were really just, on the brink of death when they arrived at the hospital. So maintaining any sort of physiologic stability in these patients was simply not feasible. And for someone who is hemorrhaging from multiple or large wounds with significant cavitation and tissue destruction, we know they require a ton of transfusion and a ton of crystalloid infusion to maintain an adequate blood pressure. But then you have this vicious cycle of hypothermia that stimulates lethal arrhythmias, causes platelet dysfunction, and then you have the dilutional component of the crystalloid resuscitation that's washing out all of your coagulation factors, all contributing to this coagulopathy and inadequate tissue perfusion. And that basically ends in acidosis. So again, you have our lethal triad that we always talk about, and then that means almost certain demise to most patients who are already suffering from profound hemorrhagic shock. So Rotondo's technique that he described in the article involved a three-armed approach that he referred to as damage control. In the first phase, you need to stop the bleeding and control or tie or staple off anything that's spilling bacteria into the field. In the second phase, you get the patient off the table, you gotta warm them up, you fix their coagulopathy, usually through transfusion, and then you try and get them off vasopressors. And then the third phase, if they look as though they might tolerate going back to the operating room, you re-explore and you finalize your surgery. You create your bowel anastomoses, whatever reconstruction you need to do, and get the abdomen closed. What Rotondo demonstrated was that for outcomes for the critically ill and injured patients, they were improved by using this damage control technique. And these patients were really sick when they came in. Here's some of the data charts for the 22 patients he considered severely injured. They were all cold, acidotic, and required enormous amounts of blood transfusion. An abbreviated surgery to tamponade or arrest hemorrhage along with the control of enteric spillage, followed by temporary closure of some form, and then reoperation only when the patient had been resuscitated to some sort of physiologic normalcy, allowed for improved outcomes, who would otherwise really succumb to the legal coagulopathy that they came in with. So at that point, the temporary abdominal closure was achieved mostly through skin-only closures. Occasionally, you see mention in the literature at that time point about a silo technique, and then you'll see coming up here that there were many, many, many different ways that we've devised to temporarily close an abdomen. So from simple packing with wet gauze covered by a clear dressing, that was one of the original techniques, to skin-only closures involving either a continuous running suture, penetrating towel clips, we've really tried just about every darn thing we can imagine to temporarily close an abdomen. The simple packing was really an issue in terms of fluid losses and trying to keep the dressing intact, proved really difficult for bedside nurses. Towel clips and running suture along the skin edges was tricky because you risk intra-abdominal hypertension and abdominal compartment syndrome. Bogota bag technique involved using those big, large, clear IV bags. You cut it up and you cover the viscera and then sew it to the skin edges. That was a cheap, easy solution, but again, you have issues with intra-abdominal fluid management, and there's no way to prevent fascial retraction, which meant difficulty when it came to definitive closure. And then you have the mesh techniques, both permanent and absorbable. With mesh closures, you can preserve fascial tissue planes, but now we have increasing incidence of fistula formation and intra-abdominal abscess. So in someone battling critical illness, the addition of infection and fluid loss from a fistula is not something we really want to introduce. Then comes the Whitman patch, which we don't get to see all that often anymore, but it definitely enjoyed a certain level of popularity because it typically did not have the same issues with fistula formation. It wasn't cost prohibitive, and it allowed for sequential tightening and hopefully eventual closure of the fascia, but then again, it did have issues with leaking of fluid, necrosis of the fascial edges, and then you end up with these big hernias. The major advances in temporary closure came in the mid-90s, and that was with the advent of the negative pressure therapy systems that we use. Barker's group out of Chattanooga, Tennessee was the first team that really developed this method and published on it, which ultimately became a technique we use most frequently today. His method is more akin to the modified negative pressure dressings that we do with Curlex, et cetera. But I'll talk a bit more about why we use negative pressure later in the lecture. But just wanted to give everybody an idea of the tons of different types of closure techniques that we've really gone through over the years. So when we leave the abdomen open, we expose our patients to a whole host of secondary insults, and the most common of which are listed here. This is by no means an exhaustive list. Ongoing insensible losses in a patient that already has a metabolic derangement can contribute to difficulty in resuscitation measures. And this is on top of the capillary leak and third spacing already occurring due to a pro-inflammatory state. So immune system modulation is disrupted. And in cases where there may be contamination, now we have a perfect petri dish for infection to grow. And never mind that the patient is likely not in an optimized nutritional state when they come in, and they probably aren't going to have adequate protein stores for healing. So over time, despite these issues, the concept of the open abdomen really provided an ease of access for re-laparotomy and second look surgeries. And then it began to start to cross over into other subspecialties of surgery. So gynecologists were using this method for obstetrical patients in DIC with severe hemorrhage. Vascular surgeons were leaving ruptured AAAs open to prevent abdominal compartment syndrome. And again, the list keeps going, which is why I want to talk about some of my personal experiences with open abdomen in the non-trauma setting. And I have several cases to present. The identifying information has obviously changed in these cases, but they were all patient care that I participated in personally during the course of my residency, where open abdomen management became necessary outside of the trauma realm. And it wasn't something we were always expecting either. So this is the most recent case I participated in. This actually just happened a few weeks ago. This is SP, he's a 64-year-old male. He was seen in the outpatient setting for weight loss and difficulty swallowing, and he underwent a number of imaging studies and diagnostic tests that ultimately showed he had two primary malignancies. One was a right upper lobe cancer, and the other was a distal esophageal cancer. The patient ended up undergoing a right upper lobe resection and a minimally invasive Ivor Lewis without difficulty, and I met him on postoperative day number 4. The floor nurses had paged me because the patient had developed postoperative atrial fibrillation, which up until that point had been rate controlled on an amiodarone drip, but his heart rate had jumped into the 150s, and he stated that he really just sort of felt very unwell and had this general sense of malaise. And at that point, nothing else seemed out of the ordinary until we scanned him. The patient had developed pneumatosis of the small bowel, and it was really diffuse. And we became concerned that there might be an issue with his jejunostomy feeding tube, because those are prone to having a lot of issues. So we took him back to the operating room and started with a diagnostic laparoscopy just to get a sense of what we were dealing with. And what we found wasn't entirely expected. The hepatic flexure on diagnostic laparoscopy appeared entirely necrotic, and there was feculent fluid basically everywhere through the abdomen. Lots of distended loops of small bowel, so we ended up converting to an exploratory laparotomy, and we found an unrecognized injury to the colonic mesentery, and the corresponding segment of colon had become ischemic. So we postulated that it was an injury that had happened during the dissection with the initial procedure, but this had caused an upstream ileus to the point that the small bowel had volvulized around the jejunostomy tube, and that was also starting to become ischemic. So the colon, the segment of the hepatic flexure was resected, and then the small bowel volvulus around the tube was reduced. And after the reduction, the small bowel really seemed to pink up, and there was no definitive necrosis anywhere. So we elected to perform a temporary abdominal closure, and we placed an abthera-negative pressure dressing. And the next day, after some resuscitation, he had the typical inflammatory response. We were able to complete a right hemicolectomy, put him back together, and then we performed a fascial closure because all the small bowel appeared viable at that stage. But the open abdomen in this case allowed us the time for the small bowel to recover, so we could limit the resection in a patient that was already battling a catabolic state from his malignancy, and he was somewhat malnourished at baseline. So that's the first one. The second case was a female who actually came in as a trauma alert. She was 49 years old. She was involved in some form of a motor vehicle collision, and the circumstances really weren't clear to us. All we knew was that she had crashed her car, and she was complaining of severe back and abdominal pain. And on her fast examination in the trauma bay, she had extensive free fluid. An aneurysmal resection because her infrarenal aorta was completely occluded, and then she underwent an aortobifemoral bypass. But by the time perfusion had been restored, the patient was on 3 pressors, and she'd received massive transfusion packs several times over. Her intraoperative resuscitation alone was 17 red cells, 12 of FFP, 4 cryo, 3 platelet, and 12 liters of cell saver, in addition to whatever crystalloid she was given. So she had begun to demonstrate signs of coagulopathy in addition to the hypothermia and acidosis, everything that you'd expect to see. So we elected to leave her open with an Abthera dressing and then bring her back after resuscitation.
All right, stand by for some technical difficulties. We're going to try to get Audrey back on.
Okay, can you guys hear me? I'm sorry about that. Okay, let me get the screen back up.
Yeah, Audrey, we can hear you.
Okay, sorry about that, guys. Technical difficulties. Where did I leave off?
You had just finished talking about the patient with the abdominal aortic aneurysm.
Okay, all right. So, okay, so this is the next patient. So this was MB. I was just saying that she was a case that I was involved with in my third going into fourth year. And she'd come in from an outside facility with some sort of intra-abdominal process, had a decent workup, but we didn't have access to all of the records. But we did know that she had a CAT scan and had apparently been diagnosed with a dermoid tumor arising from her left ovary. And then at some point had had an EGD and colonoscopy that discovered a mass in the sigmoid colon. And the biopsy surprisingly came back as squamous cell carcinoma of ovarian origin. So the patient was in a ton of pain. She really desired surgery only for palliative means because at that point she was having a lot of obstructive symptoms. And she had this persistent leukocytosis and fever despite a percutaneous drainage of an abscess in the belly. So we made plans for a laparotomy with the intent to debulk this tumor and create a colostomy for her. But this was really made trickier by the fact that the patient had a super therapeutic INR. She'd been on Coumadin for factor V Leiden. But we eventually got her on a heparin bridge and she was optimized with several weeks at TPN before her palliative procedure. So we really had done everything we possibly could to get her ready for this. These were her preoperative scans showing a really, really severe inflammatory process in her left lower quadrant. There were multiple fluid collections, several fistulous tracts between various loops of bowel. And like I said, she'd undergone percutaneous drainage of one of the larger collections, but we didn't really have great windows to do anything beyond that point without intervening surgically. Her case, as it turns out, was more complicated than we were anticipating. She had extensive omental caking everywhere and tons of adhesions. I'd say she was almost borderline frozen abdomen, but we really were able to make some progress. So she had likely perforated her colon about a week before. There were abscess cavities, fibrinous exudate really everywhere, and the small bowel had fistulized to several areas of the colon. And we ended up performing an extended left hemicolectomy with in-block resection of the left ovary tube, the dermoid mass, and then we also had to do a small bowel resection. So the dissection itself was exceedingly difficult, but once the specimen was removed, anesthesia alerted us to the fact that the patient had rapidly decompensated. She had been stable throughout most of the case after getting a transfusion for a slow intraoperative ooze, but then all of a sudden she was requiring 3 vasopressors in really a matter of minutes. So we made the decision at that point to pack the abdomen, place the negative pressure dressing, and get her to the ICU for resuscitation. This is the specimen that we removed, excuse me, and pathology confirmed that this was a metastatic squamous cell teratoma, which had invaded the sigmoid colon and had caused fistulas and perforations everywhere. And you can see in the right-hand side, the hairball protruding from the mass itself. So we were able to get the patient back to the operating room within about 36 hours, restore bowel continuity, perform an colostomy, and then get her fascia closed. Unfortunately, this patient was, really debilitated when she came to the hospital, and she lingered in-house for quite some time after her surgery. She was just so deconditioned to begin with, and she really never could tolerate a diet, although I don't think she really had a desire to eat. And eventually she was found one morning in her room by nursing and PEA arrest on the floor. So she had a DNR order in place and already, and she expired. So not all of these cases had the desired outcome, obviously, but I used them to demonstrate how we incorporated open abdomen management into non-trauma surgical care at Christiana, and how it has become a useful adjunct even when you're not anticipating the need for it. But what does evidence-based medicine tell us about these methods? What do you, as a non-trauma surgeon, really need to know about the open abdomen? Well, we have experts to help us. So there's a ton of literature out there on this subject. There's so much, in fact, that it's really difficult to sort through most of it. And a lot of the studies you'll find are like the majority of the literature in this field. They're all small retrospective case series. And I'm certain that limitations on human experience make it very difficult to put together any kind of large randomized prospective trial. So instead, we have expert panels that convened and released this consensus statement 2 years ago on recommendations for open abdominal management in the non-trauma patient. And I think this provides a really solid foundation to kind of help us determine who could potentially benefit, how do we manage these, what are the complexities we face. So let's go through some of the fundamental questions about the open abdomen. So it started with the trauma laparotomy, and I've shown 3 examples of how the open abdomen might be put into practice, but what do the studies actually tell us about the various indications? Well, there are 3 very broad categories, and sadly, they don't really encompass all the indications that we use them for, and the category names don't fit perfectly, but for now, it's really the best we've got. So the first indication is peritonitis, and this is the broadest category by far. I think it's meant to capture all manner of etiologies that lead to peritonitis. So the delineation of what causes peritonitis really was vague in this consensus paper and really in most of the studies that I read through. But the idea here is that you have a patient with peritonitis and they're in a physiologic state of shock. The open abdomen is a way to abbreviate the initial procedure so that you can resuscitate them and get them in some form of recovery before taking them back. It also provides a means for second look surgery, completion of intestinal anastomoses, and if you cannot get these all done at the first surgery, then you have an opportunity to do it when they're in a more stable state. So I don't have a specific example in mind, but if for some reason you're not able to obtain full source control at the time of an index procedure for peritonitis, it also provides a means for repeat washouts. So we'll take a look at some of the supporting evidence. This first article came out of Mexico City, was initially presented at the annual meeting of the Surgical Infection Society in Miami in 2005. Robledo and his colleagues randomized 40 patients with severe secondary peritonitis to be managed either with open abdomen or traditional single-stage surgery. Apache and SOFA scores were similar across both groups, indicating similar levels of illness severity. And the source of the peritonitis was ruptured or perforated viscus, pancreatitis, appendicitis, etc. Pancreatitis and appendicitis patients were excluded from this particular study. So patients with open abdomens underwent temporary closure by sewing non-absorbable polypropylene mesh to the fascial edges and covering the mesh with saline silk gauze, which is a method that we now consider relatively contraindicated in intra-abdominal sepsis. So this article actually argues against the liberal use of open abdomen in peritonitic patients, but we have a small sample size and the chosen temporary closure method is known for its high complication rates. So it's no surprise that you would see really no improvement using that particular technique. This is a much more recent article just from last year. This came out of the Carolinas Medical Center. It was a propensity match study of 534 patients who underwent laparotomy for non-trauma peritonitis, and it demonstrated significant differences in complication rates, mortality, and cost associated with open abdominal management. Interestingly enough, even after propensity matching, there was still significant differences in patient characteristics, such as volume of blood transfused. So that suggests to me that the subset undergoing open abdomen was still somehow sicker than the patients who were closed at index procedure. And there was also a higher rate of use of open abdomen if the case was performed in the middle of the night, or if the surgery was performed by an acute care surgeon as opposed to one of the non-acute care surgeons. So this does suggest quite a bit of bias inherent in the study, but we already know that sicker patients are the ones that tend to require the open abdomen management in the first place. Bottom line, to this day, there's still no discrete definitive evidence to suggest that open abdomen is better than fascial closure and management of peritonitis. We know that open abdominal management is expensive and that there are tons of complications, but it's still a viable option for patients who require temporizing measures until you can get physiologic derangements under control, or if you have a patient where source control is not possible at the time of initial laparotomy. So the method becomes a tool you really keep in your back pocket. It's not something you think of first and foremost when you're dealing with intra-abdominal sepsis, but it's a last resort safety net if you really need it. The other category in second general indication for open abdomen is for our lovely vasculopaths. Approximately 20 to 30% of patients develop abdominal compartment syndrome following open or endovascular aortic repair. So open abdomen has become a mainstay in both treatment and prevention of abdominal compartment syndrome. However, it's not to be used without caution because graft infection obviously carries associated mortality rates that are super high, and even in some studies quoted as high as 88%, which is a little insane. But leaving a newly placed aortic graft open to the atmosphere is never an ideal situation, and there are instances where the operating surgeon isn't left with much of a choice. So most intra-abdominal vascular emergencies entail the need for a second look operation to make sure the bowel's still alive, or you may not be able to close because of excessive visceral edema from massive resuscitation. So it's again something that we've had to use. Let's first talk about aortic aneurysms. Robert Fitzum was the first vascular surgeon really to describe the use of open abdomen in the treatment of ruptured AAA patients who had developed abdominal compartment syndrome in the late 80s. But abdominal compartment syndrome remains one of those elusive and complex entities that's really difficult to even diagnose in the first place. I think that's especially true when you're talking about patients undergoing endovascular repair because you're never in the abdominal compartment in the first place. This paper comes from a multi-center study out of University Hospital in Zurich, along with data from the Cleveland Clinic and New York University Medical Center. They looked at the collective patients undergoing endovascular repair for ruptured AAA over a period of 10 years, and all patients were monitored on an hourly basis for bladder pressures both during and after the case, and were subsequently taken for decompressive laparotomy if the pressures exceeded 20 millimeters of mercury with signs of ongoing organ dysfunction. And the authors made note of the fact that all patients in their institutions undergoing open repair for ruptured AAA have their peritoneal cavity left open empirically. So that's just a side note, but the temporary abdominal closures for the EVAR patients were either by Bogota bag or vacuum-assisted therapy overlying a zipper drape. And 20% of the patients in this study did require decompression. So of those who underwent the decompressive laparotomy, the 30-day mortality rate was 30%. All surviving patients successfully had their fascia closed in a delayed primary fashion, and 5 of the patients did at some point develop an intra-abdominal infection, although no fistulas were observed in this particular cohort. So this study had multiple limitations. 1, it was retrospective. 2, there was no control arm, but you really can't control from abdominal compartment syndrome because it's unethical to not decompress them. And 3, we don't know how long these patients were followed postoperatively. So to say that there was only X number of complications and everybody else recovered, I mean, we know that 30-day mortality was examined, but the article never mentions how far out follow-up was obtained. So their relatively low complication rate may not truly be reflective of the prolonged complications in this subset of patients. This is a study that came out about 8 years later in 2017, and they examined a cohort of 191 patients from databases in Sweden, Finland, and Norway. It included both endovascular and open cases for elective and ruptured AAAs. And that means it includes patients that had their abdomen left open at index operation and those who required a decompressive laparotomy at a secondary operation for abdominal compartment syndrome. Vacuum negative pressure dressings were used as temporary abdominal closure over mesh, which was sutured to the fascia. Again, the idea is to prevent retraction. And of the surviving patients, they were able to achieve delayed primary fascial closure in 91.8% of the patients. So they looked to directly compare those who had their abdomen left open at the index procedure versus those who required a take-back decompressive laparotomy. The patients who had their abdomens left open empirically had a shorter duration of open abdomen. They had lower rates of intestinal ischemia and lower rates of requiring renal replacement therapy. The overall mortality rate in the cohort at 1 year post-op was 28.6%, and in-hospital mortality was 39.3%. 7 of these patients developed a graft infection of some form within 6 months of surgery, which is a rate of approximately 3.7%. So the results at first glance seem kind of bleak, but mortality rates don't seem to be drastically different from any of the other studies I looked at. And by directly comparing the patients who had initial open abdomen versus decompression later, they were able to show a clear in-hospital mortality and long-term morbidity benefit from earlier open abdomen. So basically an empiric or a prophylactic procedure as opposed to a reactive procedure. Again, we have to be careful about bias here. Patients who had their abdomen left open at index operation likely had other reasons for which they could not be closed. This was not randomized, so we may be looking at some form of selection bias. And then again, entirely retrospective, so there's little, if any, protocolization or standardization in their treatment schemes, especially considering that you know, the hospitals involved in this database were all over the place. So let's jump to a slightly different version of a vascular emergency, that being mesenteric ischemia. Unfortunately, mesenteric ischemia is one of those entities which proves extremely difficult to monitor. Unlike an ischemic limb, you don't have a way to directly visualize the bowel unless you're looking right at it. So that's where the open abdomen comes in. And it's provided surgeons the ability to evaluate bowel directly when there's a question of viability, and it provides an opportunity for ease of second look surgeries. The title of this study is Survival in Patients with Peritonitis Secondary to Acute Superior Mesenteric Artery Occlusion. It was published in 2017. It really gets to the point. 109 patients, University Hospital in Nanjing, China, and they all suffered from acute occlusion of the SMA. 44 of the patients had open abdomen, 65 were closed. You have both open and endovascular embolectomies as well as stent placement as treatment modalities. There really was no difference in length of bowel resected between the two groups. However, the closed patients required additional bowel resection at almost double the rate of the patients in the open abdomen group. So likely some component of abdominal compartment syndrome there or ongoing ischemia. They also had a higher rate of intra-abdominal sepsis and need for dialysis. But most importantly, 30-day and 1-year mortality rates were significantly lower in the open abdomen group, 27 versus 52% and 31 versus 61% respectively. So that's a big, big difference. All patients with open abdomen did get to fascial closure within 2 weeks. And they didn't report any significant complications from those patients, which is a little suspect. But again, results are subject to selection bias. They're not randomized. And really in this particular group, you can't randomize. So it would seem really that open abdomen management has a little stronger data to support its use in the vascular world when compared to the general category of secondary peritonitis, which would bring us to our third and final category, which is acute pancreatitis. So we know that 85% of patients diagnosed with acute pancreatitis have mild symptoms, and 15 will progress to severe disease with multisystem organ failure. As far as we know, approximately 15% of severe cases go on to develop abdominal compartment syndrome, and that carries a mortality rate of 49%. So 1 in every 100 patients with any degree of pancreatitis will die from abdominal compartment syndrome. So surgical decompression and open abdomen management, again, remains a viable option for these people. So the systemic inflammatory response that develops in patients with severe pancreatitis combined with the high volume resuscitation that they require really can lead to significant visceral edema, causing the abdominal compartment syndrome. So they go on to propagate renal failure, reduce pulmonary compliance, a whole host of complications. So, there are instances where we just can't avoid surgical decompression when conservative methods are essentially insufficient. Mantula and colleagues looked at 26 consecutive patients at Helsinki University Hospital from 2002 to 2007 with pancreatitis and abdominal compartment syndrome requiring laparotomy. Mortality rates were much lower when patients underwent decompression within 4 days of admission. None of the patients undergoing laparotomy after 5 days in the hospital survived. So of the ones who did survive, we did see improvement in renal function in 54% and improvement in pulmonary compliance in 38%. So again, selection bias, small sample size, no consistency in how the management schemes were described, and decompression occurred basically at the discretion of the operating surgeon. They also endorsed several different techniques of decompression, including linea alba fasciotomy and transverse subcostal incisions, methods that we don't typically see anymore and have a high rate of hernia formation. And in this particular study, the intra-abdominal fistula rates were also very high, even more so when bowel resection was required. But the point I think that I'm trying to make is that there will still be a certain percentage of the population who you really just don't have a choice in. You have to decompress them. And while complication and mortality rates are high, it may be one of the only ways to save those patients. Here's another article to prove the point that we're managing really just the critically ill patients with open abdomen. This was 2019, University of Indiana. Retrospective chart review, 75 consecutive patients for severe necrotizing pancreatitis. All these cases belong to a single surgeon. 12 of the patients underwent what he referred to as damage control debridement, where they had repeat take-backs with open abdomen management, and the other 63 underwent single-stage traditional debridement and closure at the time of index procedure. Open abdomen group had higher severity of illness. They had higher rates of preoperative organ failure, higher rates of ICU admission, and higher mean Apache scores. However, readmission rates, need for repeat intervention, and overall mortality between the two groups was similar. So the authors didn't set out with the intent to demonstrate superiority of the open abdomen management, but rather utilize a control group to show that the open management was a feasible treatment strategy in the very, very, very sick patients, and that outcomes could be attained that were on equal footing with patients who only had one surgery and immediate closure. The consensus statement released by the World Surgery Emergency Group by no means recommends open abdomen as a first-line treatment scheme for pancreatitis patients, but for those that are really severely ill, it's probably a great salvage therapy. So we're seeing a theme here that because all of the complications associated with open abdomen management, we need to use it only for the worst cases when other modalities have failed to really treat or control what we're doing. So that wraps up the section on indications. And we all know that there are other instances in which open abdomen can be employed, but unfortunately there just isn't enough sound data out there to justify their recommendations. So moving on, I want to answer some of the questions about open abdomen management now. How do we do this? How do we manage these patients? So I want to first look at what's the best way to temporarily close the abdomen. The ideal method should be inexpensive, easy to deploy. You need to manage intra-abdominal fluid and then prevent fascial retraction, but we don't always have the option that we consider ideal. And in many cases, especially in the trauma world, the patients are in such a state of extremis that we don't get to utilize our preferred method of closure. Sometimes it's more about getting the patient off the table, but as I mentioned before, negative pressure systems have really revolutionized the world of temporary abdominal closure. And we slap back dressings on everything from open abdomens to wounds to skin grafts, and they really have been shown to improve outcomes in almost every situation. A number of studies have been published about negative pressure dressing systems and comparing them to other things such as the modified Barker vacuum pack. There's two negative pressure systems that are most commonly used on the market today. One is the VAC dressing put out by Acelity, and the other is the Abthera system, which we use at Christiana, that was developed by KCI. Our use of the 1010 drapes, nasogastric tubes, Curlex, and Ioban is our version of the modified Barker technique. But this is one of the largest and most recent series directly comparing the two methods, 83 patients at the Papa Giovanni Hospital in Bergamo, Italy. They were all managed for open abdomen, both trauma and secondary peritonitis etiologies between January 2012, December 2015. 65 of the patients had commercial negative pressure systems utilized and only 18 had the modified Barker dressing. There was no randomization. This was all done retrospectively. The study found there were no statistically significant differences in fascial closure rates, time to closure, or hospital length of stay. Complication rates were also similar between the groups, but what was different was the mortality rates. The patients with the modified Barker pack had in-hospital mortality odds ratio of 3.8 and overall mortality odds ratio of 4.2 when compared to the commercial systems. So Montori's paper did not speculate as to any particular reason why that might be the case. And again, this wasn't randomized, but overall patient characteristics were very similar in both groups. So there may have been some other inherent selection bias or confounding variables that they couldn't adjust for. Regardless of the reason, the same results have basically been demonstrated in multiple retrospective series. But I think this is something where it might be interesting to put together a randomized trial, since most academic institutions have access to both modified Barker dressings and the commercial dressings. And, you know, we haven't proven that there's a mortality association. It's something that's borne out in the small series that already exist. But one thing we know for certain, the commercial grade systems are way more expensive. So if there's some way to demonstrate a modified Barker dressing does not cause increased mortality, it may be a potential area for cost savings. So we now know that we need to use negative pressure systems for the temporary closure, but then we need to talk about how long do we leave the abdomen open and when do we close it. I think we've alluded to all the reasons that we want to get the fascia closed. Open abdomen exposes patients to insensible losses, the electrolyte imbalances, the infections, fistulas, hernias. So it makes sense that you want to close as soon as it's safe and reasonable to do so. And in the literature, there's some that suggest complication rates increase significantly at day 8 of open abdomen, but this isn't always the case. And the consensus statement guidelines indicate that if there's concern about source control, persistent ischemia, need for ongoing vasopressor support, or concern for compartment syndrome, then the belly should be left open. In all other cases, go ahead, get that fascia closed. And interestingly enough, the consensus statement states that acidosis, coagulopathy, and hypothermia are not predictive of maintaining an open abdomen in the non-trauma patient. But I think you'd have a hard time convincing an acute care surgeon to close under those circumstances because those principles are so ingrained in our training. This is about, this was the big study. This was the meta-analysis on closure. And it was one of the more prominent studies I came across. The paper came out of the Department of Military Surgery and Trauma at the Royal Centre of Defence in Birmingham, United Kingdom. 26 independent studies looking at over 3,000 patients. 62% of those achieved early fascial closure, which was defined within 4 to 7 days of initial laparotomy. And it was associated with a significantly reduced mortality rate, 12 versus 24%. And relative risk of complications in early fascial closure is also significantly reduced. So not only is early closure intuitive in this sense, it's also borne out in this huge series of meta-analysis. But you have to be cautious in closing an abdomen too early, especially when there's concern about all those things I talked about, like source control and ongoing ischemia. But the meta-analysis suggested that both component separation and mesh bridging are acceptable methods if you can't get the fascia closed primarily. But we'll look at specific studies addressing that issue in just a bit. How can I facilitate fascial closures? The first study you looked at, there's a number of adjuncts out there that have been explored by surgeons. One is direct peritoneal resuscitation, which is essentially instilling a hyperosmolar glucose-based diacylate into the peritoneal cavity. Theoretically, they've said in mouse models that it can cause vasodilation, increase visceral hepatic blood flow, downregulate the inflammatory response. It was like this magic miracle drug. And then this paper came out at University of Louisville for 60 patients in a 2-to-1 propensity matched retrospective case control trial. 20 patients underwent damage control laparotomy with adjunctive direct peritoneal resuscitation, and they were matched with 40 patients who did not. Operative times and resuscitation volumes were similar between both groups, but there was a significant reduction in the time to closure in the direct peritoneal resuscitation group, 4.3 versus 7 days. And the chances of closure were much higher in the direct peritoneal resuscitation group with an odds ratio of 10.1. Overall, complications were not significantly different, but there was much lower rate of ventral hernia at 6 months for the direct peritoneal group. So this paper would suggest that there's an obvious benefit to using it. We don't see it much, or at least I haven't seen it much, and my guess is that it's expensive and difficult to monitor, so that's why we haven't employed it. but there has been a demonstrated benefit in the literature. This one is a little easier to implement, hypertonic saline resuscitation. We already use it in the traumatic brain injury population, so now we're just applying it to a different patient population. This paper was 2018 out of the University of Florida at Gainesville, 189 patients either receiving hypertonic therapy or standard resuscitation methods. The hypertonic group had significantly lower resuscitation volumes at 48 hours, and fascial closure was achieved in 92% of that group versus 77% of the control arm. Renal function remains similar between both groups, but again, there was a demonstrated benefit to using hypertonic saline. Not a ton of data on this literature. There's only 1 or 2 articles out there that I could really find. They're all underpowered, small sample size, selection bias, but it's something that it's readily available to us and something that we use occasionally even in Christiana's ICU. So now that we know there are a few ways to help promote quicker fascial closure, what else can you do to improve outcomes? Morpheus has made his instructions very clear. We start extubating these patients. Less ventilator days means less hospital-acquired pneumonia, less cost, better outcomes. Most of the data comes from the trauma world, but again, you can extrapolate to the general surgery population as well. This was out of Orlando Regional Medical Center in 2018. 90 total patients stratified into 2 groups, 59 in the control, extubated after fascial closure, and 31 patients in the experimental arm were extubated while having an open abdomen. Rates of pneumonia were significantly lower in the early extubation group, although 2 patients from each group did require re-intubation. And then the analysis showed that patients with penetrating trauma, higher GCS, and lower injury severity scores were independent predictors of early successful extubation. So, patients, if you don't have a traumatic brain injury, they're more likely to be extubated earlier. So you would think that this would apply well to a general surgery population. Now that we've extubated patients with temporary abdominal closure, what about feeding them? We've already shown that surgical patients suffering from polytrauma, sepsis, hemodynamic instability have all sorts of physiologic derangements, but we haven't addressed nutrition. The pro-inflammatory state, leads to net catabolic reactions, muscle proteolysis, increased urinary nitrogen excretion, and mucosal barrier breakdown, bacterial translocation. So ability to heal and fight off infection are certainly compromised. This is a very small study, 14 patients, University of Kentucky, 1999 to December of 2000. Patients with an open abdomen were fed via a post-pyloric nasoenteric tube. 57% of patients were able to meet or exceed 80% of their expected nutritional needs. Duration of feeding had a wide range, 4 to 35 days. Intolerance was defined as diarrhea or reflux, but there really weren't any significant complications. So it really showed that it was safe to feed your patients with an open abdomen. This was a second retrospective study, similar outcomes at Vanderbilt, 78 patients, 4 days of consecutive enteral nutrition. There were subgroups, 4 patients initiated on feeds within 4 days of laparotomy versus those feeding on after 4 days following laparotomy, and there was no significant difference between the patient demographics. 74 of the patients started on early feeds were able to get fascial closure within 7 days, as opposed to only 49% with the delayed feeding. We all remember this guy. He told me very early on as a medical student, as an intern, that all you have to do is feed and water these patients, and I think that's something that we really need to remember even in people with an open abdomen. As we come towards the end of the lecture, I wanted to address the issue of delayed primary closure. There's going to be a rare subset of patients in which you simply cannot get the fascia closed despite all your best efforts. We're really trying hard to prevent enteroatmospheric fistulas, ventral hernias, etc. So we need to take a look at how we can get that closure done. Unfortunately, according to the consensus statement, there's lots of studies out there looking at mesh bridge techniques, etc., but implementing a mesh prosthesis in somebody with an open abdomen that are prone to infection, etc., you're just going to have higher rates of fistula formation. There's really no good data out there. In fact, they don't even really quote any of the studies because the data is so insufficient. But here at Christiana, we do have the benefit of subspecialists that may know exactly what to do. So let's call our hernia specialist team. So you don't want to burn a bridge in terms of as far as tissue planes go. And you only have really one good shot at a solid repair if a patient necessitates component separation. So it's always safer to get an intraoperative consultation if you've run out of ideas. Looking ahead, the field of treatment with the open abdomen continues to evolve really all the time. The focus now is on managing the open abdomen and improving the outcomes related to closure. Here you can see pictures. KCI is coming out with a new perforated sponge that's supposed to improve fascial retraction rates. There's all of these contraptions and torture looking type devices that people are coming up with now to prevent fascial retraction and stretch out the fascia and help us with closure. There's also some constructs that they're looking at that test the strength of artificial fascia that may be growing in the lab. That's kind of just the direction that this field is taking right now, and there's also a lot of investment and experiments going into biologic meshes as well. So we'll be looking for those outcomes here in the next decade or so, with the goal of getting that abdomen closed quicker and with fewer complications. So to wrap this up, these are the few things that I really hope everyone can take away from this talk. Bottom line, open abdomen no longer falls solely under the trauma canopy. It's a technique really that has broad applicability and can really temporize a critical situation and to allow any surgeon really from any specialty to get definitive closure. I think it's pretty clear from literature that we went through that negative pressure wound therapy is the preferred method of temporary closure. It's simple to use. It keeps the wound bed clean. It helps prevent fascial retraction, all while managing peritoneal fluid drainage. And you want to get that fascia closed as soon as possible. We know the potential complications are innumerable, but if you're really optimizing your treatment, you want to get that fascia closed, and there's a number of adjunctive therapies to help you do that. Trauma surgeons have historically been the most comfortable with open abdomen management because these patients tend to be in the ICU, but it's no longer something for everyone else to fear. As patients in general become sicker and sicker, we're operating on these people, and we're going to have to see the utilization of the open abdomen potentially even continue to climb. So for those of us not encountering the open abdomen on a daily basis, we may need a little help from the scientific community to develop a universal classification scheme, maybe even an algorithmic type approach to help select patients. But as technology advances, we're going to see improved outcomes for temporary closure, and that's going to help reduce our complication rates and probably help reduce our anxiety about using it in the first place. So ultimately, it's always going to come down to patient-specific criteria and the surgeon's level of comfort, but please don't be afraid to use this. These are my references, and that's about all I have for the day. I just want to thank all of the attendings, my co-residents, the support staff, and my family for getting me through the last 5 years. Wasn't an easy road, but wouldn't be here without all of you and your support. So I very much appreciate it, and special shout outs to both Dr. Weinberger and Dr. Giverson for helping me get this lecture together. And with that, I think we'll take questions, and here's the last CME code for those of you coming in late.
Yes, great job, Audrey. We'll do a virtual round of applause, I guess. And,
Thanks.
I'd say open it up to the floor, but we'll open it up to the cloud and see if anyone has any questions. In the meantime, I guess I'll ask you a question. What do you think about optimal time to return to the OR for closure? Or what in your mind algorithm would you build?
I think that's difficult to say depending on the patient. Most of the literature says within 24 to 48 hours, you want to plan at least your first take back, depending on what you're attempting to do, how bad the ischemia is, how bad the contamination is. I think waiting beyond 24 hours, you start to run the risk of adhesion. So then when you are going back, you're having more complications. But again, it's patient dependent, because you see some where you simply can't control the physiologic derangements. If you have somebody that's on 4 vasopressors and pericode, then taking them back to the operating room might not make sense. So that's where like the bedside explorations, et cetera, come back in.
Yeah, all great points. I think you just have to have that clock start to leave the OR with the intention of getting back as soon as you can, knowing that after 5 days, your rate of fascial closure is going to drop precipitously. You mentioned once you get to 8 days, you start running into that frozen abdomen and really dense adhesions. So as soon as you are able to reverse that physiology, whether it's acidosis, coagulopathy, or hypothermia, return even in less than 24 hours if you do have them corrected, because the sooner you get them closed, the better.
Definitely. Any other questions, guys?
I have a question. or I guess maybe not a question, but a comment. I mean, this is an interesting topic. I guess I would caution against using this in a few subgroups of patients. I mean, patients with Crohn's disease, I would be very reluctant. I'd rather open and close the fascia on a Crohn's patient several times than get involved with enteroatmospheric fistulas. I think I did actually run into a patient that Dr. Rotundo had operated on with Crohn's disease, and his indication was peritonitis. It wasn't a compartment syndrome or anything like that, and that patient was basically, this was more than 10 years old, and that patient still has fistulas. We've never been able to get them closed after multiple attempts. Now, my concern with using this is, I think patients with peritonitis, just peritonitis, no intra-abdominal hypertension. I know in the past this has been overused, and I hope the pendulum doesn't start swinging back in that direction. The interventional radiologists can really be very helpful in draining abscesses. I think the concept of going back into the abdomen over and over again to quote unquote wash out infection can really lead to problems. And you know, sometimes in those patients, the open abdomen becomes the disease. It's not even the original problem. So certainly for patients with compartment syndrome and the damage control patients, but I think you have to be very careful how you define damage control. I think if you spend an extra 20 or 30 minutes during surgery on a stable patient trying to wash out and make sure that you check the spots that are often missed, the the subdiaphragmatic spaces. There are areas. We had a patient recently where there was a huge subdiaphragmatic collection that I suspect was there at the original laparotomy, and it just somehow nobody got a hand up there to sort of suction that out and wash that up. So I know there's a use for this, but I think in the past it's been overused, and it does seem like the data on using this for patients with peritonitis is still quite scanty and doesn't support it that well that I can see.
Yeah, and I mean that's why I kind of caution this consensus paper statement. These groups where they were talking about indications and saying peritonitis is one of the indications. I think the literature there is much less supportive than it was for the abdominal compartment syndrome and the pancreatitis or the vascular patients that had this huge resuscitation. So I think, again, the point was that there are patients in extremis that may require it, but I by no means am recommending this in stable patients, because I think if they're stable, then you should be able to get enough control during the index operation that you'd expect to close them.
Okay, so that would be one of your take-home messages here, that this is stable patients. You have to be very cautious, unless it's in a patient that has ischemic bowel and you're doing a second look procedure.
Yeah.
I mean, you're coming back in a day or a day and a half to hopefully reconstitute the bowel.
Yeah.
Okay. Thank you. I enjoyed that. Thank you.
Thanks. Anybody else?
Hey, Audrey, do you think that the reason there's a little bit higher morbidity with the modified Baker is because it's not able to really drain the pericolic gutters and kind of really do a good job in terms of fluid management of the abdomen?
It's hard to tell, because every patient that we encounter, the habitus is slightly different. The intra-abdominal process is slightly different. Obviously, the application of those dressings is inconsistent, right? Because sometimes we use 1 Kerlix, sometimes we use 3, sometimes we use 2 nasogastric tubes. So I think it's really, it's difficult to point to any one reason, and I think the literature avoids it too. All the studies that looked at comparisons between the commercial grade pressure dressings and the modified Barker technique, none of them, not a single one, mentioned why they felt that the modified Barker had increased mortality or complication rates. They just said that they did. So there could probably be several reasons contributing to that, but I think the fact that it's an inconsistent technique, and every time we do it, we're doing it slightly differently with different things, with different materials. So it's very difficult to kind of make an all over encompassing determination about that. But we do know that there's several articles that say that the outcomes, overall mortalities are worse in the modified Barker dressings.
Yeah, and some of that may be patient selection too. And you alluded to with cost. So the cost of that there is about $400 compared to your components needed for that modified Barker back, which being about $16. So if it's gross mesenteric ischemia, you're going to do a quick second look. You really don't think the patient's going to survive or do well. I think most surgeons would probably opt for a quick Barker's vac rather than wasting the Abthera, knowing that it's not going to be applied for that 24, 48 hour range.
Yeah, and if you're doing multiple washouts in the ICU or something like that, I've had several patients where I've opened them 3 times in a 24-hour period. There's really no point in using the Abthera system then.
Hey, Audrey, this is Dr. Irgao.
Hi.
I enjoyed your talk tremendously. That was very, very thorough. Congratulations.
Thank you.
So I have 2 questions. The first question is, I want to know where Dr. Densman got his haircut. The second question is, I'm always puzzled as to how little laparoscopy has penetrated the trauma world. So thinking about the next generation of the acute care surgeons and trauma surgeons, do you think there will be a shift away from the need for the open abdomen in general?
I don't think that there's going to be a need for shift away from the open abdomen, because I think that even in the trauma world where you have patients that go for laparotomy and we really don't have significant findings at the time of surgery, those patients are closed. But you're always going to have patients that are severely injured where laparoscopy just isn't going to be sufficient, major hepatic lacerations, IVC injuries, anything like that. Those patients are going to have open bellies, even if you started laparoscopically to see what the initial injury was. So I don't think that there's going to be a trend necessarily away from the open abdomen, because I think that's always going to be your last resort safety net for the really, really critically ill and injured patients. But I do think that there's going to be an increase in the use of laparoscopy for traumatic patients. And the perfect example of that are minor stab wounds where you have like a small blade or something like that. I've used that a number of times. In fact, specifically one of the first cases when Dr. Weinberger came back after his fellowship training, we had a gentleman that was stabbed that needed some form of exploration, and we opted to do it laparoscopically. We didn't find any injuries, and that was the end of it. We stuck a scope in and we were done. So not so much that there will be less open abdomen use, but more so that we will see higher numbers of diagnostic laparoscopy and even potentially robotic use in the future for trauma indication.
Right. So because one of the advantages of the open abdomen, at least that was touted in the past, is that you're able to relook at the abdomen, right? Mm-hmm. And see if the injury has progressed or something else has happened. But with laparoscopy, you are able to do that very, very easily with a second look without obviously creating the trauma of the laparotomy. So
correct.
Yeah. So hopefully that will be the way in the future. Thank you.
Mm-hmm. Thank you.
Audrey, great job. Very proud of you. That was excellent.
Thank you.
And I also wanted to add to Dr. Irgo, yes, we are working on trying to create a minimally invasive surgery task force. As a matter of fact, I belong to one of those groups at East, the Trauma Society, to try to see how we can apply minimally invasive surgery in trauma a little better. And there are actual reports. So you're all invited. We have a symposium actually that happens in January at East. This next time is going to be at Disney. So you're all welcome to attend for that minimally invasive surgery trauma task force. But anyway, excellent thank you for mentioning the Bogota bag also, which is really the aging bag. So that was very, very good. Bye.
Thank you.
All right, nice job, Audrey.
Thank you.
Everyone have a good day.
Thanks, everyone.